Okay, so this is now, we're just going to talk a little bit about the procedure itself, and then at the end we've got a video of an actual sort of pelvic vein embolization procedure, or certainly parts of it. So again, just to go over the procedure again, the first thing is just to look at the anatomy. And when we look at the anatomy, the reason the anatomy for me is so important is because I get asked the same question by patients all of the time, which is, you know, you've said you have to go into a vein in my neck. I don't want someone to go into a vein in my neck. A lot of people just are put off by that thought. So they always ask the question of, why do you have to go in a vein in my neck? Why not a vein in the groin, for example? And when you look at the actual anatomy and you think about the physics of what I'm going to do, it sort of answers the question. So these are the veins, and this is essentially the main vein that drains up back to the heart. This is the vein that drains to the left kidney. This goes to the right kidney, and you've got the ovarian veins that come down here, and you've got the internal iliac veins that come down here, and then you've got the external iliac veins that go down to the groin. So people say, well, why can't you just go into the groin to get into all of these veins? And I think that's probably quite a good question. But when you think about what I have to do, essentially, I've got to put a tiny needle that's about that big and hollow into a vein, and then a similar sized tube I've got to pass into these veins to block them off. So if I've got a very, 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 very long, thin tube that I need to place into one of these veins, I need to do it in the most sort of straightforward manner. So if I go from the groin and go up, I've got to come up and back down on myself to get into this vein. I've got to come up and back down on myself to get into this vein. And then once you get into these other smaller branches, you've then got other curves to negotiate. So essentially what I want is a straight route to all of the veins, and that's what will make life easier. So if you want a quick procedure that we can do in 45 minutes to an hour with the least possible sort of fuss, then what I want is a straight route into every single vein that I can possibly target. So of course, if you're coming from above, you've got a straight route into the ovarian veins, you've got a straight route into the ovarian veins, and you've got a straight route into the internal iliac veins. So it is much, 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 much more straightforward just to go from a small vein in the side of the neck. And in terms of what we've discussed about pelvic reflux can present in two fashions. So one, it can come out onto the legs, and when it comes out into the legs, it can corrupt the vein in a different way. So it can actually corrupt some of the leg veins itself, or it can actually corrupt a vein at the back of the leg, or it can actually just come down from the pelvis and not affect any of the actual leg veins, but just the veins from the pelvis itself come down and cause varicose veins. And what we see in terms of the statistics, we see that the most common percentage of reflux is in these veins. And when you actually look at the combination of veins where the reflux is, we see that bilateral internal iliac vein and the left ovarian vein, so that combination tends to be the most common pattern of reflux within the pelvic veins. Now obviously pelvic veins can come out onto the legs, like I've just said, and cause a leg vein pattern, or they can stay within the pelvis and cause purely pelvic symptoms. And I do see pure pelvic symptoms very commonly without leg veins. And the symptoms can be all of the symptoms that we've just described with pelvic congestion. So you can have the person that walks through the door that says, I've got heaviness in the pelvis, it's painful, it's dragging, it's worse towards the end of the day, I get pain on intercourse, I've got irritable bowel symptoms, and I've got irritable bladder symptoms. Or you can just get one woman that comes through the door and says, I've been diagnosed with multiple UTIs, I've got urinary frequency, do you have any of the other symptoms? No, you don't. You shouldn't discount pelvic congestion, because I've dealt with those patients, and by treating the pelvic reflux and treating the veins around the urethra that Angie showed, those symptoms of frequency of micturition, and hence people think because you're peeing a lot you've got a urinary tract infection, will go away. So pure pelvic symptoms are very common, and leg symptoms are very common, and a combination of both are very common. So when we're doing the procedure, what we're wanting to do is we're wanting to block off the veins. And you asked the question really about how many coils or what veins, to what extent do we go down into the veins, and how many of them do we block off. So essentially there's 4 territories. So there's 2 ovarian veins that come down, and there's 2 internal iliac veins. And the ovarian veins are very simple. If we just briefly go back to the diagram, the ovarian veins, very simple. Nice long vein here, then it branches. Nice long vein here, then it branches. So all you have to do is get the catheter into there, drop a little metal spring called a coil in each one, and that's the ovarian veins dealt with. No problems at all. The internal iliac veins, you can see here, that they form a much more complex network. So at first we thought, well, how can we take off that pressure, that reflux back down into the pelvis? Well, surely if we just take out this vein here, that's good enough. So, you know, when we were first starting, or when I was first starting, we thought, yeah, put in a big coil in that position here, one on that side, one on that side, and just stop the reflux into the internal iliac veins, and that will solve the problem. But it didn't at all. And actually, the patients got no benefit from that at all.
If you're cutting off the veins at that level,
yeah,
they're obviously serving a blood supply to things like, you know, the ovaries and so on and so forth. How do those maintain their viability? So
they're draining the veins from those organs. So those organs are getting their blood supply from the arteries, yeah, and the venous drainage from those organs is coming back to the heart.
But it still needs to happen.
It does, but you've got such a complex pattern of, or network of veins within the pelvis, that actually blocking off that main vein will make no difference whatsoever to how those organs will drain. And that's probably why the patients didn't get any better, because of course what they've got is they've got other veins that are coming around that are still draining those veins. But as well as draining those veins, of course that means they're feeding those veins, and if the reflux is still there, then the reflux still goes on. So actually blocking it off up here is no good. We need to get further. We need to get further, and we need to get deeper into those veins to get a more, well, to get an air response and to get a more durable, lasting response. So that gets a big cross. That's not how you do pelvic vein embolization at all. That's how you do pelvic vein embolization. So now you've got smaller coils, but the coils themselves are much deeper into the veins. And actually the regions that we're looking at are, they're twofold. They're an obturator vein that comes down the side. This is called your obturator foramen, and there's a high frequency of obturator veins spilling down onto leg veins. The ones that come underneath this dark structure here, which is the bladder, they tend to be the pudendal veins. And it's the pudendal veins more than the obturator veins that would cause problems with pelvic congestion syndrome, and the ovarian veins. So this, for example, is the obturator vein coming down, and this vein will then join onto the leg. So what we've done, through this tiny tube that goes all the way down, we've placed the black coil. This is the black coil there. That then sits in the vein. The vein hates that because there's something foreign in the vein. So the vein clamps down onto that coil like that, squeezes all the blood out of it, and then that vein essentially is destroyed. So the immediate response to that, of course, is that any form of congestion, therefore, may just feel a little bit worse for a day or two, because, of course, now the blood hasn't got the easy route out that it was using previously, and it opens up other routes and other veins to drain. So initially, after pelvic vein embolization, there will be a period of probably about 1 to 3 days where you may notice some pelvic cramping, bit of an ache in the bum and in the thigh, and that's simply that slightly exaggerated congested feeling before everything then starts to improve. So this is the network of veins that are coming down. These are your pudendal veins. Picture on the right just then shows the coil and the pudendal vein. And these are just more pictures, of course. So now this pattern here, this is an ovarian vein. And if you follow the contrast, you can see it's coming down and actually across this pubic bone here. So that's spilling out from the ovarian vein out onto the vulval area. And that's the coil then going upwards in the ovarian vein.
Did it say that was 40 centimetres long?
Yeah. So the coils are 40 centimetres long, and I can make it look however I want. So obviously if I just push the coil straight out and pull the catheter straight back, then you'll just get a long bit of metal. If I keep the catheter where it is and just push the coil out, then you'll just form a little tight bundle of metal. If I push the coil out and bring the catheter back a little bit as I'm doing it, then you can control how the spiral of the coil forms. And that's just the technique, because you want a combination of both. You want to embolize the whole vein, but you equally want to make sure that it's tight enough that it's not going to let any blood go through.
And I think it's an extension of what he was asking, but so as you said, the coil's in there, the vein clamps around it.
Yeah.
There's a point where the blood is sort of coming up to that point. Is that just closed then? What happens to all this stuff? Does it rot away, or does it just stay there?
The vein?
The vein around the coil.
The vein essentially, I mean, in 2 days nothing's going to happen other than the vein clamps down under the coil.
Yeah.
2 weeks, 2 months, 2 years down the line, that vein's just fibrosed.
Right.
It's just a...
Coil remains.
Coil remains.
Blocking the whole...
Blocking that vein. Blood's found a different route, and therefore you haven't got the reflux pouring down into the pelvis anymore.
Right. There's no danger that it could get out around the coil and into some sort of cavity or outside of the vein structure?
The blood? No.
Right.
No. And in actual fact, you know, sometimes when you're... I mean, in this case, I have gone from the groin. This is a male patient, this. Now, if you put the wire out, sometimes these veins are quite fragile, and you can easily push the wire outside of a vein wall. Doesn't matter. You know, this is not an artery. You're not going to, you know, you're not going to suddenly bleed from this. You know, as soon as you do any damage to the vein responds by shutting down on it.
Right. And what's around them? Because they're not in space, I guess. The veins, they're surrounded
Just supporting
by
tissue, you know, fat, mesenteric fat, muscle. Yeah.
It's like a boost, isn't it? It's like a boost. So
Yeah.
it's like when someone takes blood from you.
That's
That's why if you keep taking blood from the same place, eventually that you can't do that because it's shut down. So people with cancer, for instance, they have to keep changing where they take blood because it doesn't like. Yeah. I mean, if you leave a cannula in the back of a hand, it'll get infected. The vein hates it. It's a foreign body. You know, it's the same thing with a coil. Essentially, it's just going to cause that destruction. How long have you been doing this bit? How long have you been doing the
coiling?
Yeah,
in the world, or me personally?
Yeah. Well.
I mean, coil embolizer, putting coils into veins or arteries, has been done now for 20, 30 years. Okay.
Did you realise it didn't work and you had to go further?
Yeah, I mean, that was probably back in 2007.
Okay.
So
nearly 10.
So yeah, nearly 10 years of sort of really distal coil embolization.
Nobody has actually come up with the artificial valve rather than shutting these things off.
It's been tried. It's been tried. Not in the pelvis, but people have looked at that in leg veins. People have looked at ways of reconstructing valves in the leg veins. And I would probably, Mark's not here at the minute, but ask Mark to go on that side of things. But it just hasn't worked.
But it wouldn't do if you're saying that you can't treat the leg veins anyway. If you need to go right back to the pelvic region to treat
Yeah, I mean, obviously, once you've developed the varicose veins in the legs, yes, you could potentially stop the reflux by putting in an artificial valve. But at the end of the day, the veins are still going to be varicosed in the leg then. They're still going to be there.
Right.
The coils themselves that we use are quite special. And the reason that they're quite special is because, and you can see here that what I'm doing is, this is the catheter tip, and I'm pushing the coil out, and then I don't like where it is, so I'm pulling the coil back. Okay, so the coils are called repositionable coils. So if I don't like the position of the coil, I can pull it back into the catheter, say, nah, I don't like that, change the position, put it into a better position. So rather than just, you put the coil out and you think, oh, I don't like that position, but then it's out, I can actually change the position. Obviously, once you go away from having had the procedure done and the vein clamps down onto the coil, then the coil is in there from that point on. We're talking about lots of coils. This is probably, one of the most that we've seen. Here I'm injecting contrast. What's black is dye. You can see it spilling down through the vulval veins and down onto the leg. So there's definitely, you can visualize what's happening during the procedure. You can actually see the contrast, you can see the veins, you can see where it's going. And these are just more pictures showing the network of the veins.
Complications through this at all?
So the thing, what I tell all the patients, and I think it's really important to realise, is that it's walk in and walk out. So people immediately think, great, and they walk out. And they'll walk out of the procedure, 99 times out of 10, they'll go home and then everyone thinks, wow, was that it? That wasn't even as bad as going to the dentist. But then you'll go to bed, you'll wake up the following day and then you'll feel really washed out and just a bit tired and just think, whew, bit achy, sometimes maybe have a low-grade temperature, for example, for a day or two. And that's called post-embolization syndrome. So any patients where you embolize tissue, you put coils in, you put particles in, they seem to get this. The more coils you put in, the more regions you treat, the more likely you are to have that. Should only last a couple of days. Okay, in an extreme sense, it might last a week. The other thing is because you block the veins off, so initially you're going to get that congested feeling that I said about, so cramping in the pelvis, the thigh, the bum, and again 1 to 3 days. So if you go away from the procedure, take ibuprofen and paracetamol for 3 to 5 days, chances are all of those symptoms are going to be minimised. What you're probably referring to really are there any other serious complications from this? Now, when these cases were first being done, someone reported an incidence of what we call coil migration. So the coil that was placed then travelled somewhere else. And of course, where it's going to travel is back up to the heart, around the heart, and then lodge in the lungs. And they said in about 1% of cases, the coil migrates. I've probably done, I don't know, somewhere between 300 to 500 of these now, and I've not had a coil migrate. Now, I think that probably is because when that first person was producing his figures, he was producing his learning curve of the first 100 cases. And in the first 100 cases, he'll have been doing exactly what we've all done, and that's refining our technique. So, for example, not putting the coil in that position. He'll have been putting coils deep down. He might have been looking at the vein saying, it's a 5mm vein, we'll put in a 5mm coil. Of course, then the patient stands up and the vein isn't 5mm anymore, is it? It's 10mm, so the coil can move. So we tend to use standardized diameters now, around about 10 to 12mm. So the coils are all 10 to 12mm, and we're putting them really deep into the veins and we're embedding them in there. Now, obviously, if you've got a short coil that's only, say, 2 centimetres long as well, that's more likely to move. If you put a coil that's 40 centimetres long, you're actually winding it into multiple territories of veins, and it's just going to stay there. And so I've never seen a coil migrate. The other thing, in terms of your earlier question about how deep we can get into the veins, so, for example, on this case here, we're treating this vein, this pudendal vein here. Now we know, just like on this side, the veins go further down. They have done. They've gone into the vulval area, the vaginal area. But I've only got one coil deep here. I'm not getting coils any deeper on that side. So what you can do, once you've got your catheter in place, is you can use the same Valsalva manoeuvre for the transvaginal scan, and you can inject the foam sclerotherapy. And what that will... Sorry? Through the long tube, so that the foam sclerotherapy won't come out up here. Obviously, it'll come out where the end of the tube is, which is down here. And if you then Valsalva, it pushes it into the vulval veins as well. So you're going to get much better embolization with the STS and the coils together. Okay, but the STS will irritate the veins, and as soon as you inject the STS, potentially you will shut off different routes of veins because the veins don't like it and they close down.
Does this ever have any impact on the lymphatic system at all?
No. Not in the pelvic veins. And I mean, it's not going to have an effect on the lymphatic system. It may have, you know, if for example, you know, someone blocks off a major vein to the leg, then you're going to get leg swelling. But that's venous drainage, that's not lymphatic drainage. So this won't affect that. Coils and the STS will not affect pregnancy, they will not affect fertility. Obviously, we don't advise STS because it hasn't been investigated in pregnancy and breastfeeding, so you shouldn't give it therefore in pregnancy and breastfeeding. So if your
What's STS?
STS is the form of sclerotherapy, so you shouldn't inject that if your patient's pregnant. What you can, or breastfeeding. What you can say if the breastfeeding is you could express for 48 hours worth of milk, we can inject the STS and then within 48 hours it'll be out of the system. But strictly speaking, we shouldn't be doing this in patients that are breastfeeding either, because the hormonal the hormones that are in the body during breastfeeding and pregnancy will cause the veins to dilate anyway, so it's not a good time to perform any of these procedures.
And have you had anyone who's had this procedure coming back some time after saying the pain's worse or no better? Well, I presume no better is a possibility, but worse, is that a possibility?
I mean, we've certainly had patients whereby, and this has always been the problem, and this is where we rely so heavily on our sonographers, because it is, at the end of the day, it's a clinical call between seeing reflux on the transvaginal scan and having symptoms suggestive of pelvic congestion syndrome. So when you Google it and you Google what's the results of pelvic vein embolization, you'll see in the literature it'll be 10% to 90%. I mean, that's a huge variation, and you know the reason there's a huge variation is because nobody is using, or certainly, well, we believe we are, but the gold standard for diagnosing it. Some people use CT, some people use MR, some people don't use anything. They just embolize all 4 regions. So it's very difficult to give those sorts of percentages. This is a short video just of the actual sort of clinic room in London as well. So Matt's just going to play that. What you're seeing essentially, and I'll just talk over the video somewhat, is you're seeing this machine here, which is just what we call our C-arm. That's what shines the X-rays. This is looking at the X-ray itself. This is the catheter that's coming down, okay? And it's the X-rays are just allowing me to visualize that catheter. And then I can steer that catheter. You can see it hasn't got much of a curve on it. It's only got a tiny little angle like that. So that's what I mean about needing a straight route. And then all we're doing is we just follow the catheter down. This is a intrauterine coil device that's in situ. And then we just use this very, very fine wire and tube. Again, you can just see the tube moving on the left of the screen, and in a second you'll see the tube on the right of the screen. And that's injecting the contrast. That shows where the veins are. That's giving me a map of where I need to go. And it's very much just standard practice that we embolize the pudendal vein, we embolize the obturator vein, and if they're abnormal, obviously on the transvaginal scan, and we embolize the ovarian veins. They're the roots, and they're the veins that we try to embolize with a combination of coils and STS. So this is an oblique view, and you can see veins swinging around here, and you can actually see the vein coming round and then actually spilling down further onto the vulval area and then onto the legs. So if we've allowed for it, you'll probably see me then coiling that. That is the tube just on the outside of the patient that you saw. That's the coil just going in, and you can see as I'm coming back, this is in an ovarian vein now, I'm just allowing the coil to form its loop. If I didn't bring the catheter back, I would just have a little bundle of metal here, but you know, we're actually using the full length of the coil to try and block off that vein.
Is the shape that the wire is now following, is that following the shape of the vein?
It's just following, I mean, the overall shape will follow the length of
like
the vein.
Tube.
Yeah.
But
you're not going to have this beautiful coiled symmetrical spring.
Yeah.
So you know, coming up the vein.
It doesn't look like from that shape that it's going to stop liquid, but it's the vein clamping around it.
Exactly. It's the fact that it's a foreign body.
Right.
Okay. The coils themselves, and what you're not seeing on the coil here is you're just seeing a long piece of metal, but the coils are made of platinum and they've got Dacron fibres on. And the Dacron fibres cause more of the irritation as well as the actual metal coil itself. The reason the coil, of course, is made out of platinum is because, one, it's completely inert. So I've never seen ever a patient have any form of allergic reaction to the coil, or any coil anywhere in the body. And that's obviously very important. And the other reason it's platinum these days is because everyone has an MRI scan at some point in their life. So everyone asks the question, can I have an MRI scan after this? And yes, you can. These are MRI safe.
So someone carrying 30 coils around is worth a lot of money.
Yeah, but they will not set a metal detector off either. They will not set a metal detector off. And when you come to the clinic, I can probably show you one of these coils. They're not how you imagine. They're almost just like a piece of hair plucked from your hair. They're that thin, they're that flimsy there. They've got no significant structure and rigidity to them. You've got this impression of this really rigid piece of metal, but it's not at all.
Where do they make them?
Sorry?
Who makes them? Where are they made?
They're made from, probably, but yeah. But I mean, they're made from thousands of different companies. You know, will have different coils. The coils that we choose are by a company called Boston Scientific, and I just like them because if I don't like the position of them, I can just pull the coil out. Okay, and the other thing that it allows me is that sometimes as you're pushing the coil out, if you meet resistance, it pushes the catheter back. So it's like me just pushing a wall like this. If I put my hand this, you know, it pushes me back. And sometimes what can happen is you can be in the best position in the world, and as you push the coil out, it pushes the catheter back, and then you lose that position. But because this coil is actually part of the wire, until you fully deploy it, you can actually simply push the catheter back over the coil. So it allows for really nice sort of tricks and techniques to use.
How do you deploy it?
Literally, there's a clasp mechanism. So the coil is 40 centimetres long, and it's attached to a wire by a simple clasp like that. Just like that. And so when it's in the catheter, it's like this, but when the back end of it drops out the catheter, it just becomes free. So you've got until the last half centimetre of deploying that coil, full control. And then once you're happy, you just
must be able to know exactly.
Yeah, I mean, to be honest, this is really safe territories. This, if you're training a registrar, not that we do, but you know, in my NHS practice, if I'm training a registrar to do coil embolization, these are the ideal cases to train people on, because simply the anatomy is so safe, effectively.
And just the foam is not used. This is your question, I think, is because platinum's more reliable inside the body than the foam. No, I mean the foam is used to cause a chemical burn. So the foam will cause a chemical burn to the vein wall. Okay. Now, obviously, you know, it will cause a chemical burn to the vein wall of the vein that you injected into. If it's rapidly excreted out of that vein, it's neutralised, but then that's not a normal vein. So an abnormal vein will hold the foam, it will sit there, it will cause a chemical burn to the vein wall, and so the reason to inject the foam is just to get that little bit more distal embolization. But if you imagine 4 territories of veins coming in, and I come into one territory and they're all connected, and I inject foam, all that happens is it shuts down all the other three territories. Now I then need to find those other 3 territories. So actually foam is counterproductive for what I want to do then. So the best thing to do is to actually embolize, and what I found is embolize the 3 regions first, or 2 regions, or however many, and then when you're in the final region that you want to deal with, then you inject the foam. Because actually then it's not going to go anywhere, because one, you've blocked all of the exits with coils, it's going to hang around more in the region that you're going to treat, and you just get a better result. So yeah. Stunned.
Have you ever had anyone that's got pregnant after having that?
Yeah.
And did they have?
The only negative thing is because the stresses that pregnancy puts on the body. Okay, it puts on stresses in terms of increased blood volume. It puts pressure in the pelvis and therefore reduces or causes an element of venous obstruction. Therefore, the risk of developing more veins is higher if you then become pregnant and breastfeed again. But it's having that balance, because actually, you know, I've had a colleague as well that's had some procedures whereby they've, for example, well, no, it wasn't a colleague actually. This was a different patient, but they had a subsequent pregnancy where the varicose veins were very bad. Now it's obviously then you know, do you embolize the patient? In fact, I had a patient this morning we were having this very discussion about, do you embolize now, knowing that things are going to therefore be better in subsequent pregnancies, yet you potentially may have a higher risk of recurrence? Or do you do nothing now, bearing in mind that you're probably then going to get pregnant and then have significant varicose veins in pregnancy? And unless you've seen someone with significant varicose veins in pregnancy, you know how painful they can be. You know, you're then having to wear compression stockings, compression pants, and you've got this little sort of thing combusting. And, you know, you're then wearing all these extra hosiery, and you're just basically just hot pot then, really.
So it's a very difficult decision, isn't it?
It's hugely difficult, and you know, all I can do is sort of state the facts. I don't want to be the person that makes...
So if you say you had the baby, how long would you leave it till you did the test? Because I assume you wouldn't do it until you could treat it, and you can't treat straight away.
Exactly, and there's no point in doing it while they're breastfeeding. So it would be after breastfeeding finishes.
But how long after breastfeeding?
It can be just a matter of weeks, really. I would give it about just 2 weeks after breastfeeding.
And what about if someone decides not to breastfeed?
Then that's fine. But obviously, give them the 6 weeks per period period to be over with, and then they can have the scan. Because obviously, you know, that 6 weeks is all about return to normality, as it were.
Yeah, that's what I just wondered. What the time limit was. Okay.
Just got one more question. Sorry if you've covered this already. If you're embolizing different veins that are coming into that area, and so you're closing those off, and the blood then finds other ways out. Yeah. What's to stop the varices happening again on these other routes that it decides to then take? So you have to go through the whole process again.
Yeah, it's more to do with the anatomy and the way the ovarian veins, for example, come down. So you've got a lot more gravity hitting that. Similarly with the internal iliacs, if you then open up the other veins, it tends to be much more sort of collateral veins, smaller veins, multiple networks of veins that will cause, you know, you just don't have the same volume of blood when you stand up, for example, crashing into that area.
Okay. So you're, instead of having some big motorway type ones, you're closing those off and sending it out through lots of smaller roads, distributing it?
Yeah.
Okay. So there's not that much chance of requiring the whole procedure over again?
No.
You haven't come across that?
I mean, don't get me wrong, people can have a recurrence. I mean, and we're discussing obviously in pregnancy, for example, so it does happen, but it is rare.
And I presume if you're treating 1 quarter, because I only need 1 quarter done, I guess pregnancy could put strain on the others.
Yeah, yeah. You know, unless we suddenly see 4 veins from the onset and we treat all 4 veins, but then we'll be treating potentially a vein that's normal. But yes, you could have 2 veins that are abnormal, get pregnant, then after embolization, and then the 2 that were normal then become abnormal. So.
Give a talk. This is a very précis of a talk that I was asked to give last year at the National Conference for Vein Surgery and Vascular Surgery called the Vascular Surgical Society, and I was asked to speak because at the moment, as you probably know, in England, very few people have pelvic veins treated at all.